Good afternoon, everyone. Thank you for joining us for our second iteration of our Paying for Value webinar series. Today we're going to talk about the Accountable Care Program financial approach and risk sharing. My name is J.D. Fisher. I'm a health policy analyst here at the Healthcare Authority. And our presenters for today are going to be Kate Walker, a senior health policy analyst at the Healthcare Authority, and Ben Diederich, a consulting analyst at Milliman. Consulting actuary, excuse me. Before we get started, let's go through a couple of housekeeping things. Please make sure you're connected through audio. You have two options, either your microphone and speakers through your computer, or you may dial in with your telephone using the dial-in number and your access code. If you have questions, we'll have a brief period for Q&A at the end of the presentation, and please use the webinar panel to submit questions during the presentation, and we will take note of them and get to as many as we can at the end. Today's presentation has three purposes: to discuss HCA's financial approach to its Accountable Care Program contract and how risk is shared between the Healthcare Authority and the Accountable Care Networks, to understand where this model fits in on the national scene of payment redesign, and to provide insights into how employers can approach risk-sharing contracts for their health benefits. And with that, I'll pass it off to Kate.
Thank you, JD. Good afternoon. I wanted to start out just to provide some context of where our ACP contract fits within our larger Healthier Washington initiative. As you're aware, the initiative focuses on three areas, all focused around the triple aim. Those areas being healthier and engaged communities, improved health outcomes, and payment reforms. Our ACP contract addresses all three of these investment areas with focuses on population health, focuses on the outcome-based results through our financial model, and upside and downside risk sharing. Next slide. Some of these slides will be familiar to some of you who have seen some of our other presentations through Healthier Washington, but under our HCA purchasing goals, by 2019 is our intent to move 80% of our state-financed health care, that's inclusive of our Medicaid and our PEB populations, as well as 50% of the commercial health care market into the value-based payment arrangements as defined under the HCP land framework. And we intend to have this measured at the provider level when we are considering those percentages. In addition, it is our intent to move the annual health care cost growth to be less than 2% of the national expenditure trend, again by 2019. Next slide. This is our HCP land framework on alternate payment models, our value-based purchasing spectrum, as it were. Of particular note, I wanted to call out that as we continue to discuss our UMP Plus option, we have that defined under Category 3B, an alternate payment model with upside gain sharing and downside risk. And for our attributed population, we have that defined and called out as our ACP UMP population, which is a Category 3A, which is a ultimate payment model with upside gain sharing only, which we'll be going into more details on that this afternoon. A brief overview of our public employee benefits program that we offer here through the Healthcare Authority. PEB purchases health benefits for approximately 360,000 state workers and their dependents, retirees, as well as political subdivisions, including some K-12 organizations. We offer two fully insured products and one self-insured product. Our self-insured product we refer to as Uniform Medical Plan, or UMP Classic. We also have our two managed care organizations through Group Health and Kaiser Permanente. We have, within those carriers, we offer typically three different benefit design packages, or historically we have. We have our Classic, our Value, and our CDHP plans with associated health savings account. But in 2016, we offered two new plans. We offered the UMP Plus benefit under our self-insured product, as well as Group Health's new offering called SoundChoice. So we want to go into our ACP product a little bit more. The ACP difference from our UMP Plus plan differs from our UMP Classic plan in the following primary areas. First and foremost would be the network differences. UMP Plus offers what we refer to as a narrower network, not necessarily what we view as a strict narrow network. And we have those two network accountable care networks that we contract with, the Puget Sound High Value Network and UWMedACN Accountable Care Network, providing the network availability under our UMP Plus plan. We also, with our UMP product, we work directly with the provider systems. We meet with them frequently 2 or 3 times a week as we work on operations and policy and care transformation activities. We have a significant amount of involvement and interaction with them. We also have the designated population, and when we say that, we're referring to people who have actively enrolled in UMP Plus. So during open enrollment or when they signed on as a new employee or became eligible for benefits through the state, they elected to enroll in the UMP Plus plan, and thereby the plans then have upside and downside risk associated for those members who enroll. Lastly, there's substantial differences in the cost sharing for UMP Plus as, in contrast to UMP Classic. That takes the form of member contributions for the premium being approximately 30% lower than the premium that members pay for Classic, and that's across all benefit tiers for individual, employee-only, employee-spouse, employee children, and full family coverage. And additionally, there are other cost-sharing differences around, primarily around primary care office visits, which we have no cost-sharing for in-network visits in UMP Plus, as opposed to a co-insurance model under UMP Classic. Additionally, another difference in our ACP product, which does have impacts on the UMP Classic and UMP CDHP plans, is that the attributed population, meaning those that met a particular logic with the providers that they saw the last 2 years, they became attributed members to the network where those providers were, and the networks then had the ability to have upside gain sharing for that population. And that is to say that this is a population that is nested within our UMP Classic and UMP CDHP populations under our self-insured plan. Next slide, please. Again, a brief overview of the actual plan itself of UMP Plus. The goals being stated very clearly there: to improve patient care and the patient experience that's received, to focus on the whole body through integrated health, integrated care, focusing on the head and the body care, and then the financial and clinical accountability on the networks for this population. For 2016, we have 2 networks that we're working with. Again, it's the Puget Sound High Value Network and UWMedACN Accountable Care Network. And for 2016, this was offered in 5 counties: Snohomish, King, Thurston, and Kitsap counties. And currently we are working to expand the availability of this plan to other counties throughout the state of Washington. In addition to horizontal expansion, offering this to more counties, it is our plan to encourage and recruit more employers and other political subdivisions to either join PEV or join in comparable efforts to our ACP plan for their populations, thereby vertically expanding the availability of this product. And again, as it is right now, this is only available to those employees who live within the 5-county Puget Sound region. So now we'll start getting into a little bit more of the nuts and bolts of the financials, which I'm sure the crux of our presentation here today. So starting from the top side, it is a model that's built on a shared risk foundation, upside and downside, with the focus and emphasis on bending the cost curve, which is our way of saying, reducing the trend while also increasing the quality of care. This is our value proposition. Value in healthcare we define as the result of quality over costs. It's a simple mathematical equation, but we want to recognize the intrinsic relationship between quality of care and the cost of that same care. On the upside, the network contracted with are incentivized through rewards for their high-quality care provided by these networks, and provides incentive payments based on the achievement of savings in excess of the targeted cost reductions. In addition, for the designated population, networks have financial risk for the quality of care should it diminish or fall below certain target parameters, or if the financial targets are not achieved, the networks are at risk for those amounts. I wanted to highlight for those of you who are familiar with the contracts themselves that we have posted on the Healthier Washington website, links of which were included in the last presentation and which are included at the end of this presentation. I would welcome you to go and review. They are redacted for the proprietary components that we were obligated to redact, but the know-how and the crux of the financial model and other components are still left available for you to use and to understand. So I wanted to highlight the primary sections within the contract here, sections 2.7 and 2.8 of the bulk of the contract, and then looking at Exhibits 3 and Exhibit 5 for more components of our risk-sharing model. So how does it work? Performance incentives and penalties are tied to measurable improvements, which is a key component. We want quantitative analysis of these areas, or if there are not improvements, the lack thereof, for areas such as cost and quality, member experience, and clinical outcomes. Again, we have two populations under the ACP. That is to say, there is an attributed population, which are those state workers and their dependents who are in either UMP Classic or UMP CDHP, who attributed under a particular logic to a member in one of the networks that we've contracted with, but did not actively enroll in UMP Plus in the plan. They fall into our attributed population and are subject to, or they fall into the pool that has upside gain sharing only. Then we have our designated population, which are those members who have actively enrolled in UMP Plus, and the networks have upside and downside risk sharing for those populations. So you have the passive, attributed population being passive in the ACP, and then active enrollment. There's a separate financial reconciliation for both of those populations that occurs separate from each other. The upside for attributed and downside for upside and downside for the designated population. We recognize the reason why we set up an attributed population largely stemmed from the recognition that we would not be able to completely transition our self-insured product entirely into our UMP Plus product. So thereby we wanted to provide some financial incentives for the care transformation activities and to also bring along additional provider groups into value-based purchasing contracts by having a larger pool available for those populations. The trend guarantee, the trend savings guarantee that we have built into these contracts, it is an annual trend savings guarantee found in Exhibit 3, Sub 2. These were negotiated with the networks and set based upon those negotiations. As such, the example that I've included here on this slide is purely exemplary of a type of trend guarantee that could be negotiated for. In this particular example, it would be considered a more provider-friendly trend guarantee as it begins in a smaller end and allowing for care transformation activities to be put into place before the full financial effect might be realized at the end of a 4-year contract. Again, if you were to engage in these activities on your own, these rates would be part of the negotiations. They are cumulative year over year, meaning each year the percentage trend reduction is aggregated and cumulative 1 year to the next, as will be demonstrated in a later example. It's important to recognize that this is just one component of cost PMPM for this model. There are other components that we'll go over briefly, and is relative to a benchmark trend established by the benchmark cohort. Further understanding of the cost, the target cost development beyond just the trend guarantee is that, again, the trend guarantee is just one component, and other critical components include a base year of 2015 considered costs for the PEB population. We also have several different concurrent risk scores that we consider for our financial reconciliation, starting with a base year risk score for the population and a performance year for the population. Then we divide those out for consideration between the attributed, the designated, and the benchmark cohorts. Real quick, a word on the benchmark cohorts. The benchmark cohort is defined as the population in UMP Classic, UMP CDHP, the attributed population, and all other PEV employees who are not enrolled in UMP for the performance year. The benchmark trend from base year to performance year is also a key component for the target cost development. All these definitions I give in trying to explain components of our financial model, and then I will go over in a little bit more detail with a couple of examples that I've created at the end of my portion of the presentation. So we also want to consider the fact that we have components that will reduce the deficit should the network have a deficit in a performance year. These criteria include things like after-hours access, whether or not they met our standard for providing access to primary care providers in outside of the typical 8 to 5 or 8 to 6 business times. We also have obligated the networks to provide our members with a personalized contact center, and we have set performance parameters around time on getting in to see a provider or being able to speak with a representative, drop call, other call center performance parameters, as well as the use and adoption of electronic health records and the attestation that they and their providers and partner providers are engaged with meaningfully using EHRs. Other deficit reduction factors include a reduction for the late delivery of data and reports. And I add this in here because it is recognized by our operations team that the critical nature it is of having timely delivery of data reports to our networks, as we're expecting a lot out of them for the quality components that they are obligated to perform under, risk financial penalty. It is incumbent on the healthcare authority and the plan sponsor to ensure that the data reports that are required for reporting and for care management be delivered in a timely fashion, and so we have included deficit reduction should we not provide data in a timely manner to the networks. And also we have a quality model or a quality improvement model found in Exhibit 5, which we'll go over in the next slide. Our quality improvement model rewards achievement and improvement through greater savings and lower deficits. This is to say that the quality improvement model has two components, two primary components, an achievement score or a quality score and an improvement score from year over year. The Quality Achievement Measures program found in Exhibit 5 creates a measure we call the Quality Improvement Score, and it's calculated with those two variables on achievement and improvement for 19 quality measures. These 19 quality measures are a subset of the statewide common measure set. For those of you who are familiar with the statewide common measure set, know that this was created by a committee that was appointed by the governor that select and agree on how to measure quality in the state of Washington. This committee was created to inform public and private healthcare purchasers, which presented helps present a pulse on our delivery system. The quality model can reduce savings from the maximum amount of the shared savings. Poor results on the quality improvement score can reduce the savings, and good results will increase the total amount of savings. And then the converse is true for the designated population. The quality improvement score can reduce the deficit owed by the networks to HCA for good performance. A little bit deeper into the 19 measures that were used for the quality model. I have them listed here. I want to point out that I've listed this in a comparable way that was listed in the contract, but noting that in the middle there are 4 measures: member satisfaction, timely care, member satisfaction with provider communication, member satisfaction with office staff, and member satisfaction with overall provider rating. Those are directly pulled from CG CAP scores, We have obligated the networks to conduct member satisfaction surveys to the enrolled populations, and those scores will be used in this quality improvement score for determining their financial reconciliation. The targets for these scores were mostly set around the 90th percentile, and those targets scores were largely pulled from NCQA and HEDIS measures for the clinical and claims scores. I want to apologize. I attempted to try and create an example of how we calculate a quality improvement score for an individual measure. If you are familiar with the contract in Exhibit 5, you will note that there are several lengthy tables that are used for the calculation of the score, and I just wasn't able to come up with a coherent and relatively short-winded way of describing how these scores are calculated. But needless to say, a score is calculated based on an achievement level, and then that is combined with an improvement level from the year prior to create the total quality improvement score, which then adjusts the net savings or the deficit payments. So I want to get into an example before I go too much longer. This is purely an exemplary walkthrough of our financial model. This is not using any of the negotiated proprietary numbers that we have negotiated with our networks. We've fabricated this for the purposes here today to demonstrate how this all comes together, tying it all together as it were. So let's assume that we're going to do a financial reconciliation for a second performance year for an attributed population. So we know that we're looking at the second year, which would mean that our trend guarantee is now going to have a cumulative from first year and then the second year. The attributed population means that we are going to be considering that there could be upside and downside risk associated with this population. So we have set the benchmark trend standardization for risk for this performance year at 14%. For the hypothetical attributed cohort, the base year risk score of 1.650 with a performance risk score of 1.810 and a base year PMPM cost of $300. So to calculate the target cost, I'll just walk through this equation with you. We had, some of our numbers have changed. So we have a $500 base year PMPM with a target cost calculated as that base year PMPM times the ratio of the performance year risk score to the base year risk score times the, so I apologize, there's a couple of different changes on that, times the 1.16, which is the bench trend standardization for risk. Then we have a 0.98, which would assume a 2% reduction in the trend for the first year, times a 0.97, which would have been assumed 3% reduction in trend for the second year. And that would be the calculation for the target cost. Then we move on. Let's assume we have a quality model result. That's the quality improvement score times the negotiated base shared savings rate. And we would assume for this hypothetical that after those calculations were done, we had a 50% savings share for the network. So we know that a savings will result when the actual cost is less than the target cost, and a deficit occurs when the actual cost is more than the target cost. For the attributed population, we know that there's only a risk of upside, so that we wouldn't be worrying about a deficit. If we have the established target cost from the previous slide of $605 per member per month. Let's assume for this purpose, for actual cost scenario 1, we have a PMPM that's realized at $575, resulting in a savings of $30 per member per month. With the 50% shared savings, the network would then receive a $15 per member per month savings share. Under scenario 2, we have an even more significant savings. The realized cost of $501 per member per month for savings of $104 per member per month. The network realized $52, or 50% of that savings per member per month. This might look a little more familiar to what you see in the contract. In the contract, there are a couple of examples that are given for the financial model hypothetical. I want to include examples in both ways to demonstrate a little bit more of these models and hypotheticals. So if we were to walk through the third column for 2016, this assumes that there would be, I want to give an example of a deficit year. So we walk down, we can skip down really the same process that we were just undergoing until we get to the considered amounts, PMPM for 2016 of 560, with the target cost for 2016 being 553.08. We have a deficit of 692 per member per month. Given that this is a deficit, there is no shared savings, and we will assume this as being the designated population, the deficit share being 40% after it's being calculated with the quality improvement score, would result in a deficit payment to the plan sponsor of $2.77 per member per month. Then we would see, we'd move to 2017, and let's just assume that the care transformation activities took hold and the networks were able to realize better cost savings for the network because of the care transformation activities. We see that the considered amounts, well, first I'd like to note the benchmark trend rates, the annual trend guarantee rates, those numbers are the cumulative rates. Instead of parsing them out, seeing a 7.5% and then an 8%, that's the cumulative amounts, not just a standalone amount. Then we move through, we see a $37 per month, per member per month cost savings with a hypothetical savings share rate of 25% after the quality improvement score adjustment. We see that the network would then receive $9.25 per member per month for the 2017 performance year. A lot of numbers. I apologize if I lost some of you there. I lost myself several times walking through and trying to put these together. But I would trust that those who deal in these avenues with some regularity will find these to be fairly straightforward. And I'd welcome any questions on those. In the meanwhile, I'd like to now turn the time over to Ben Diedrich, a consultant actuary from Milliman, who has been our rock star in understanding all of these components of our financial risk. And he has graciously agreed to share some comments and some insights as he's participated in this process since we started. So Ben, I'll turn it over to you.
Thanks, Kate. Yeah, I'm here to keep the numbers straight for everybody, hopefully. So we're going to start off with what the role of the actuary was in the process. We tried to advise, from my perspective, the healthcare authority during negotiations as the financial structure was really an evolution from the starting point that we had and a collaborative process back and forth between the healthcare authority and the network partners to determine that we had a financial agreement that was sound to both parties. The actuary also calculated the technical components of the financial reconciliation, so we'll be involved in the processing of the data to determine the risk scores and the reconciliation of the financials with the benchmark trend calculation as well. We also had to, a lot of the evolution process was to adjust for differences between public purchasers and commercial purchasers. In the webinar last month, we heard from Boeing, and so when the healthcare authority took their process of accountable care to the networks, we really had to do a little bit of a phase shift to go from that private to to public model. I just want to highlight, next slide, on a couple of the technical details for consideration. So the ACP agreement that Healthcare Authority has signed with the networks, it's a retrospective settlement for savings or deficit payment between the Healthcare Authority and the network partners. Everything is still running on the backbone of the third-party administrators. So unit cost contracts are still being negotiated between the healthcare authority's self-insured vendor and the network partners. This arrangement for the accountable care program sits on top of all that interaction. In addition, one important technical note is that the benchmark trend is the performance of a peer group. And that peer group performance is beneficial because it reflects a lot of the things that the population under management is going to experience, in the fact that, like, for example, if a new blockbuster drug were released within the treatment of care for the population attributed or designated, the peer group would also pick up that relative average use rate of that blockbuster drug. So as we were going through the evolution of the model, having a standardized benchmark that, as Cade mentioned earlier, is the entire population of PEB with the exclusion of the UMP Plus population, we're able to get an established spending pattern before we have any of the adjustments for the risk or morbidity shift that the current population we're evaluating for performance may have. So one of the upsides to that is, like I said, we don't have to make a lot of adjustments within the performance measurement for things happening outside of the agreement with the networks. The one sort of concern is that because the benchmark is retrospective, the performance of that is unknown as we're emerging through the performance year. So we're starting here in 2016, the first year of Healthcare Authority's agreement with the network partners, and we don't know exactly how that benchmark performance is going to be, so you kind of have this unknown level of effort that the network partners are going to have to produce in order to achieve the savings or bring actual cost in below target cost. The other last thing is that we've adjusted these allowed costs when we're talking about sort of the high-level financials of the performance of the contract. There's also provisions within, you can see within the redacted version, where we're removing the allowed cost for certain considered amounts. The considered amounts are to reflect conditions that perhaps the network partners weren't planning on providing for all of their enrollees, or Healthcare Authority may reflect a center of excellence for a certain procedure. So those are conditions, provider types, procedure types. We also have a provision of stop loss for large claimants. So there's a couple small little technical details in the administration of the financial reconciliation that we've kind of glossed over for today. Next slide. One piece I wanted to try and loop back to is the employee contributions. As Cade mentioned, part of the incentives for people to join into the UMP Plus was both the lower cost sharing at point of service, but also lower employee contributions. So the way Healthcare Authority calculates the state employee premium contribution, so that's specific to those state employees, is it's already on a risk standardized basis. The risk scores used in employee contribution are a prospective nature, whereas the risk scores used in the settlement of the accountable care program are concurrent in nature. So there's a little bit of a difference in how we kind of use the savings from the accountable care program to then ultimately fund those reduced employee contributions. At some point in the future, once actual results for 2016 are known, then we'll have a better gauge of what the program is bringing in terms of premium reductions. The other interesting observation is that initially with the UMP Plus program for that designated enrollment, having a lower monthly employee premium contribution, like Cade said, is that it's actually attracted a healthier than average population. So there's lots of theories as to why that dynamic is happening. One of my own personal theories is that the narrower version of the network attracted people that felt like there was enough of their providers within the group that they would be willing to go through the multi-levels of benefits. And then, like I said earlier, the next slide, the enticement for enrollment had two pieces. We had the lower employee contribution, and then we had the reduced cost sharing. When Milliman also helps the Healthcare Authority not only just in this accountable care program financial reconciliation, but we also help with them setting the employee contributions. They were able to use the financial actuarial value calculator to try and estimate how lower they wanted the cost sharing to be to determine the incentive. And just some last closing observations on risk-based contracting. We have the Centers for Medicare and Medicaid Services, CMS, has released the Next Gen ACO Medicare arrangement. Next slide. And we're also hearing here at Milliman that some risk-based contracts are based on prospective cost targets rather than the retrospective cost that we're using here. We also have seen that in addition to retrospective settlement, you've got a one more slide up. We're still on 25. In addition to seeing retrospective settlement, for the retrospectively attributed population, and that was another area we kind of skipped over in the overview, the way the Healthcare Authority Accountable Care Program works is individuals are, as Cade mentioned, attributed passively throughout the year of 2016, and it's possible that depending on how the person seeks their care, they could be what we would call tentatively attributed to both accountable care partner networks, and then it's not until the end of the year after we've evaluated the full 24 months of experience ending in December of 2016 that we'll go back and definitively attribute all the members for which they were accountable over the first performance year. So in addition to the methodology that healthcare authorities employed, we also have some retrospective settlements for prospectively attributed populations, and that would be a different model than what we've described today. There's a much greater reliance on risk adjustment in risk-based contracting. So the model that is established within the ACP agreement is intended to standardize for changes in risk both in the base year, which is fixed at 2015, and each of the subsequent performance years. It's also there to standardize the risk shift that's been experienced within the benchmark trend. So it's really an independent evaluation of how the healthcare authority program spending has been performing over the 4-year duration of the contract. And we're really looking at these risk-based contracting mechanisms as alternatives to unit cost containment strategies. And with that, I think I'll turn it back to you, Cade.
Great. Thank you, Ben. So the last part of our presentation here is to address the employers who are on the line and those who would be tuning into this presentation at another future time. We would ask that if you are interested in shared risk contracting, the first thing to do is to ask your plans about how they're measuring their value. Are they incorporating performance measures? Are they incorporating quality and clinical measures? Are they measuring and rewarding based on member satisfaction? Inquire what they are doing with it within their plans. While they might not share specifics, they sure might be able to, they sure should be letting you know what they are doing to measure the way they are addressing quality and cost for their providers. Ask about the specific quality elements or add quality elements to your contractors if you have self-insured products within those. And those can take a shape, similar shapes to what we have put in with our ACP contracts. And I'm confident there are other ways to go about adding quality elements to your contracts. Ask your brokers. We are working hard to educate brokers about value-based purchasing and what the healthcare authority is doing and how we are trying to help push the market, and not only through payers but also for the providers as well. And talk directly with your providers. The more that we have providers talking to the plans and the payers, saying that our patients want to know about quality and what we can do, and we are interested in participating. We're seeing a bit of that now, and it's encouraging. So we encourage you, as everyone who's a patient at some point in their life, to talk with your provider and encourage them to begin to take on risk-bearing contracts and focusing on quality and value-based purchasing. So A list of available resources I want to walk through real quickly. Our request for application, all these are available on the Healthier Washington website under payment model pay for value and then payment model 3. These are listed there. I've included these as hyperlinks for when you are able to access the presentation. We have listed the full request for application for our ACP product. As I mentioned earlier, we have the contracts of both of the networks. And you can see the similarities of those contracts in their redacted forms. We also have additional attachments and exhibits from those contracts that are available. The paying for value summary, our overall policy statement regarding our HCA's paying for value strategy. And we are available to meet with you one-on-one or provide technical assistance if you were interested in wanting to pursue comparable value-based purchasing goals and targets that we are engaged in, and make ourselves available to meet and assist you as to the extent possible. So now with that, I think we've got a few questions here, and Ben and I will do our best to provide answers to them.
Thanks, Kate. Thanks, Ben. So one of a very timely question came in. Does the Accountable Care Program meet the alternative payment model track requirements under the new MACRA proposed rule?
Off the top of my head, I think that it gets very close. One key difference is in the EHR requirements. While we require the use of electronic health records for participating providers, I know that we have not necessarily required it in the same level of meaningful use as is under the MACRA requirements for that. Some of the other components, we are evaluating that right now, and we'd be happy to provide more information on that in the future. But I think it's a very good thing to keep in mind as the MACRA regulations, the first set of regulations came out last week. So I think it's a very timely one, and one that we'll certainly be keeping our eye on.
Thanks, Kate. And another one, this one more relating to Medicaid. Will similar risk contracts be implemented through Apple Health as well?
Again, that is a good question for our future. We are currently developing our strategy for value-based purchasing under Medicaid to achieve our purchasing goals of 80% of the providers providing services in our Medicaid contracts to be in really it's on 2C of the land framework spectrum. So as we continue to evaluate and strategize on that, certainly components of the ACP will probably find its way into Medicaid. What those are and how that will look entirely, we're still working on developing that strategy.
And Ben, maybe you could take this one. What risk adjustment methodology is used in the ACP contracts?
Sure. So the ACP contracts standardize using a concurrent risk score currently provided using the Verisk DXCG model. So we standardize similar to the example, both the base year cost by its risk score and the performance year cost by its risk score.
Great. And maybe passing this one back to you, Kate. Can you expand on what you mean by recruiting other employers to adopt ACP-type plans?
Yeah, so we have really two tracks in mind when I refer to recruiting additional employers. The first would be if an employer falls within the categorization of a political subdivision, which includes entities like hospital districts, fire districts, city governments, county governments, school districts, educational service districts, other public entities that meet the classification to be a political subdivision. We'll be reaching out and with recent legislation that was passed that helps facilitate political subdivisions joining with PEB and having their purchasing combined with PEB as the purchasing entity. We would be outreaching to those political subdivisions in the near future to encourage their participation with PEB, thereby also being able to participate with our ACP program. On the other track, it's reaching out to commercial employers, employers that don't meet the qualification to be a political subdivision, engaging with them to encourage their adoption, and if they find the value in what we're doing and they want to have a product like this for their employee population, that we would reach out to them, provide technical assistance and other supports that would help other purchasers, employers to adopt similar ACP program, recognizing that no program, likely a program in different iteration would end up being different just by the very nature of a public versus a private contract for these plans. I think that, yeah, so those are our two efforts. We're also, again, as I had mentioned, engaging with brokers, engaging with them for their book of business, helping to proliferate the use of accountable care-like programs for other employer groups.
Thanks, Cade. And this question came in, how much public transparency will there be around plan performance?
So I think it's in regards to, this would be that's a good question. I would think that a lot of the performances of these networks, because of the common measure sets, would be known in a broader sense. Reporting by the alliance for the networks will be available. The transparency from our side on the actual performance, I don't think that's something we have addressed yet. I think that is something that when the request comes in for that information, then we will have to go through our public records requests and address what information we would be able to release publicly or not.
Thanks, Cade. And we have another one here. Are some of the commercial carriers adopting Payment Model 3 type contracts in a similar vein to the Accountable Care Program?
I would say right at the top of my head, Boeing has adopted a very similar ACP contract, or Model 3 type contract. King County is also been a partner with us on our development of Model 3, and I would expect to see them having a similar ACP product sometime in the near future. Ben, are you aware of any other entities that are engaging in a comparable contract?
I think there's different flavors. The accountable care is definitely in that Category 3. I think we've seen a lot of expansion in the Category 2 as well, where you're linking to some sort of quality and value score, if not a reward or incentive, some sort of percentage increase to their fee schedule.
And I also apologize, I misheard the question. It was also relating to commercial carriers adopting Model 3. And to my recollection, yes, there are health plans that are, and payers that are, commercial carriers that are adopting Model 3 type contracts.
Yeah, I agree, Cade.
And I think that's all the questions we've received so far, so thanks everyone for tuning in. And also want to mark your calendars for our next webinar in this Paying for Value series. Will be on June 13th at 1 o'clock in the afternoon. And it'll focus on value-based benefit design. And for more information, please contact Cade, and his contact information is up. And I believe that concludes our webinar.